We have a great panel today. Each of the panelists will talk a little bit about their discipline, and then we're going to open this up to questions and answers. So this is really set up as a question and answer format. I do apologize for the size of the room. It seems a little overkill, but we'll make it work. So there's a mic on this side. If you need a mic, there's a mic on that side as well. If you need a mic, raise your hand and we can try to get you one. But it is such a big room that as you ask questions, we will have to ask you to go to the microphone. So I'm Ellen Wagner. I work with PPMD. I've been around the Duchenne world for over 20 years. My son passed away 4 years ago. He was 19. I am the manager of community centricity for PPMD. So I do a lot of work across all disciplines, kind of representing the family and the voice of the family as we look at our programming and we look at what's going to be important to us this year. So I'm really happy to be here, and I'm happy to introduce my great panel. So I'll introduce them, and then one by one, they'll talk a little bit about their discipline, and then we'll open the floor for questions. So Andrea Miele is from Children's Hospital of Colorado, and she's going to talk about neuropsychology. Rob Benjamin is from Duke, and he's going to talk about endocrinology. Jacob Kaslow is from Vanderbilt, and he'll talk about pulmonary. And then Linda Cripe will talk about cardiology, and she's from Nationwide Children's. So we'll start with Andrea.
Hi, everyone. Good afternoon. My name is Andrea Miele, and I'm a pediatric neuropsychologist at Children's Hospital Colorado. I'm in the Department of Neurology. We neuropsychologists are focused on brain to behavior relationships, and that's kind of a confusing phrase. But what it means is that we take care of kids who have a medical illness that is causing cognitive problems. And we try to understand it by having the kiddos complete a wide battery of assessments that are paper and pencil, and some are on iPads now, that last several hours, and this tells us about cognitive functioning in terms of strengths and weaknesses, because everyone has strengths and weaknesses. But what we want to do is better understand them so that we can guide the school and guide families about how to provide the best intervention and how to meet your child where they are, and then appropriately encourage them to make progress. The other part of a neuropsychological evaluation includes discussion and evaluation on mood and social emotional functioning. We do interview and ask about that part as well.
Thank you. And next we'll hear from Rob about endocrinology.
Yeah, hi everyone. I'm Rob Benjamin. I'm at Duke, and I'm in pediatric endocrinology. And unlike my colleagues to my left, my pulmonary and cardiology colleagues, I think endocrine has not always been a mainstay in neuromuscular clinic until recently. But there are a lot of topics that we talk to families about, and many of them have to do with the long-term effect of glucocorticoids or steroids on the body. We touch base about how being on long-term steroids may prevent your son from being able to make steroids on their own. That's a topic that we try to talk to everybody about. We talk about the impact of glucocorticoids, steroids on growth. As we know, there's a lot of growth suppression or impairment of normal growth velocity on steroids. And then we also talk about puberty. And that's a topic that not everyone always wants to talk about, but a really important one. Steroids, when given over long periods of time, can really blunt puberty. I almost prefer the term blunt more than delay it, because I have some 19-year-olds who haven't really started into puberty. And then all together, sort of a mesh of all those problems comes with bone health. And we know that steroids impact bone health. So a lot of really important topics, and I welcome your questions.
Thank you. And Jacob will talk about pulmonary.
Yep. Hi, I'm Jacob Kaslow from Vanderbilt in Nashville, Tennessee. I'm a pediatric pulmonologist in our division with emphasis on neuromuscular diseases. And so I help run our Duchenne's clinic. We tend to focus mostly on both symptoms as well as lung function testing. We're heavily involved with our sleep medicine docs, and we tend to do all of the sleep medicine for our neuromuscular patients, knowing that that tends to be some of the first symptoms that these patients have. We're also very much involved with our DMEs, or so our durable medical equipment companies, case management, because many, if not all of our patients require some sort of respiratory devices, whether that be cough assist, non-invasive positive pressure ventilation, sometimes mouthpiece ventilation, and things of that nature. And so we tend to handle all of that.
And Linda, about cardiology?
Yep, Linda Cripe. I'm a pediatric cardiologist at Nationwide Children's Hospital and work in the comprehensive neuromuscular program there. We definitely now have 3 cardiologists associated with our clinic, and we're really starting to focus on the nuances of treating advanced cardiac dysfunction. I think that the late childhood and early tween years are really critical years for thinking about the cardiovascular health of your child, and I look forward to answering questions and talking to you guys today.
Thank you. Okay, we're going to open up to questions. We want to have a really robust discussion here. So who wants to start us off? Okay, it's rare to be in a Duchenne room when nobody talks. Come on, guys. Okay, here we go. I heard somebody say they'll start.
I don't know if it pertains to this panel, but I haven't seen anybody that it could pertain to except this one, so maybe. We were at another conference a few months ago, and we met a few families that have recently put their boys on metformin to help with their weight gain. Is this something any of you guys have heard of or would suggest or would recommend? Our son Mason, he's 11, and he started on prednisone, and he gained a lot of weight. And then he was switched to deflazacort, and he stayed pretty steady. But now he still just looks really large, I guess. So one of the parents we met said that helped reduce some of his inflammation after they switched him, their son, and they put him on metformin. I don't know. Is this something that you guys have heard of?
Address
Okay.
that. Yeah, thank you for bringing that up. Metformin is a very well-known medicine to endocrinologists, probably to some outside of endocrinology even, because it's used so often in the management of type 2 diabetes. It's a medicine that helps decrease the amount of sugar that comes out of your liver. One of the things that steroids do is increase that amount. Unfortunately, steroids are usually stronger than metformin and sort of win that tug of war. But metformin, as you mentioned, can have some beneficial effects on weight. It doesn't usually have dramatic impact on weight gain, though. It's not an appetite suppressant. It does have it can have some stomach side effects, which can make it hard to tolerate. We always say take it with food if you're going to do it. We haven't put people empirically on metformin in our center, though.
Okay.
It's a very safe medicine, though, aside from being hard to tolerate.
Okay, yeah, because our neurologist, he was a little hesitant. He's like, so I didn't push for it, but I don't know.
Yeah, it's a great question.
Okay, thanks.
Thank you. Over here we have one.
My question about cardiac health. So if the kid has a normal function, young kid, 4 or 5 years old, on echo, a normal heart, what would you recommend to do to prevent cardiomyopathy? How early would we start some lisinopril or any other preventative measures? Normal function, normal echo.
And how old? Normal echo?
4 years old, echo was done
Yeah.
a couple of months ago.
Yeah. I think that's a really good question, and it's a controversial question amongst my peers. Some people think that there may be some benefit to starting ACE because if you think about it, the myocardium is affected in the same way that the skeletal muscle is affected. And just because we can't see it on the echo doesn't mean it's not there. So there are some families who really advocate for wanting to start an ACE inhibitor earlier, maybe at 4 or 5 years of age. And then there are other families that say, we're going to wait until we see cardiac dysfunction. And I would think that The care considerations or the documents that have been published, the consensus documents would say that you sort of wait to start an ACE inhibitor maybe until 8, 9, 10, or at least beyond an ACE inhibitor by the age of 10. But you could make an argument to start early. And so I think that's a conversation that you have with your cardiologist. There are things that sort of trip me into starting it early. We do cardiac MRIs as soon as the child can cooperate in the scanner, and 15 to 20% of our patients will have evidence of myocardial fibrosis on cardiac MRI. In those instances, I definitely would start an ACE inhibitor earlier. I mean, I think at 4, you're fine. You don't need to make that decision right away. But you will meet families at this conference who say, yeah, we put our child on an ACE inhibitor at diagnosis, and there'll be some families who will say, well, we didn't start it until age 10.
And follow-up question. So you mentioned 15-20% of your patients have, on MRI, have some evidence of fibrosis. Is it patients with normal echo?
Yes, yes, yes. An echocardiogram is an ultrasound, and it doesn't allow us to see fibrosis in the myocardium, which is why we recommend doing cardiac MRIs. The cardiac MRI not only provides us information about how well or how poorly the heart is squeezing, but it allows us to see if there's any scar tissue in the myocardium. Now, we don't want to sedate the child or do general anesthesia to get that information, so we tend not to do it in the 4-year-old, but we do push for it in the 6 or 7-year-old because we have a good child life group at our institution who works with us in the scanner to try to get those scans without any sedation.
Last question. What labs would you recommend besides, echo? Let's say the patient has a normal echocardiography results, and do you have any suggestions for early detection without cardiac MRI to kind of, see the trend without, putting the kid through general anesthesia?
Yeah, that's a tough question, and that's a question that challenges the cardiology community. There aren't any real good markers of disease progression in the young child, except for cardiac MRI. I mean, I think cardiac MRI is, which is why the cardiologists are now pushing that, because it does allow us to see fibrosis occurring in the myocardium earlier than we have in the past. But a normal echo is great, don't get me wrong, but it's not reassuring that the disease is not progressing in the myocardium.
Okay, thank you.
Thank you. Next. Okay, now I have to ask the questions, and that's a lot of work after lunch. Oh, good, here's a person.
Hi, yes. I have a 12-year-old son. He's non-ambulatory. He lost ambulation at 10 years old. And I was wondering, with that loss of ambulation, he's also put on a lot of weight, of course. And so, of course, we worry about his pulmonary and cardiac function now that he's not getting exercise in the same way that he used to do. What would you recommend for that pulmonary and that cardiac health that we could do with him being in a wheelchair and being somewhat limited as far as like the physical therapy that he can receive?
I can go first. So, yeah, common question, concern, especially with families when their boys lose ambulation. So things like pulmonary rehab, I mean, that's kind of what I'm calling it, but not in the same use that the adult colleagues would use that. But things like water therapy are always good when we lose ambulation. Even PT, OT, being able to come up with and devise systems that help with taking those big breaths, the changes in ventilation, because those will be helpful. At that point, we also start thinking about learning like breath stacking, where we take a breath, hold, take another one, so we can start expanding and using those muscles. It doesn't necessarily prevent the progression, but what it does is allows us to develop those techniques. So if we get into a situation where we do have shortness of breath, we do have issues, we have the ability to do those without the use of like an accessory device.
Sure. Thank you.
And from a cardiovascular standpoint, I think watching his weight is really critical. That can't be overemphasized, and it's really, really challenging. I mean, when you're non-ambulatory and you're on steroids, you're starving, and your daily caloric requirements are very low. But trying not to at least not gain weight, I think is important. And I think you can sort of do that as a family, and I mean, that's good as for the whole family's cardiovascular health. Keeping an eye on the blood pressure, I think, is reasonable too. Steroids can cause your blood pressure to become elevated. So watching the blood pressure, I think, is important. And I would also agree that water activities, I think, are extremely reasonable and seem to be enjoyable and allow a freedom of movement that doesn't tax the myocardium. And
Wonderful. Thank you very much.
And I'll just add on a question. Dr. Kaslow, what about a cough assist? Is that the time that you would introduce a cough assist?
So there are a couple of things that go into when we initiate cough assist, one of which is, once we've lost ambulation, we start thinking that a cough assist is a useful device. We do a lot of it based on symptoms as well. A lot of parents say, oh yeah, the cough seems fine, but then we dig a little bit more. And I'm not so concerned about the strength or if it sounds good. I care if the cough itself is effective. Right? If it seems like when we're sick, we have something in our throat, we have a lot of increased secretions and mucus from like a viral infection. If it takes a lot of coughs to clear the airway, that to me signals that our cough is not effective. We also, at every clinic visit, we do peak cough flow as well. And so based on the guidelines, we definitely initiate once we're below about 270, 280. But a lot of it is based on our symptoms. But yes, once we lose ambulation, my threshold for initiating cough assist is much lower, if not to just have in the home. It doesn't have to be a daily thing, but the kind of thing I always recommend turning on at least once a month. And that is so when you do need it, you're not running around looking for the cord, we're not looking for the plug, dusting off the spider webs, that kind of thing. We know it works because, hey, just once a month we turn it on, we use it, okay, it's fine, we'll put it away till we need it, that kind of thing.
Great. And what about steroid regimens? So we're talking about weight. What are your thoughts on daily steroids versus weekend dosing? There's a lot of dosing choices out there. What are your thoughts on that? Sure, yeah. Dr. Benjamin, you can take that one.
I would just add, when we were discussing weight and how hard it is to control when you're on a medicine that stimulates appetite, we also have to remember that it suppresses growth. And so your ideal weight is often lower than it might otherwise be if you're not growing. In terms of different steroid regimens, I've seen very similar hormonal impact from Emflaza and prednisone. I think there's a hope that some of the newer forms coming out may have more favorable effects on growth and development. I have not noticed a big difference with weekend dosing versus everyday dosing on some of those endocrine manifestations, but to be fair, I haven't had that many patients on weekend dosing yet. But I know that question's coming up a lot more in clinic.
Yeah, it's very neuromuscular provider dependent. Yeah. And even at our institution, we have sort of the daily steroid provider and the weekend dosing provider. And they're very passionate about those decisions. I think as a parent and as a person who's outside my box, my only advice to you would be that there never within this field has been an enormous amount of uniformity of decision about what is the optimal steroid regimen. And I think just to appreciate that that is a controversial decision. So if your child doesn't seem to be doing well on the steroid regimen that they're on, whether they're gaining so much weight or they're having behavioral issues, to really pursue a different steroid regimen or to have that discussion with your provider. Because it may be that if you're having trouble on daily steroids and you go to weekend steroids, you may have less trouble. So I think I would just continue that dialogue with your neuromuscular provider.
I think we have a question here.
Okay, with that, so my sons are on weekend high dose. My younger son experiences a lot of like autism tendencies also. Our neurologist doesn't agree that I should have him tested for autism, so I just haven't. That's my first question. Like, should I kind of push for that? He says he's kind of too old, but I feel like he's getting a little worse. And his teachers don't notice anything because when he goes to school, he's totally okay, I guess. But he'll come home and he's like a nut, like crazy, like all the time. So that would be my first thing. But then I was wondering if the high dose weekends might be adding to that, because it seems like on the weekends it's so much worse. Like he's crazy. And it's usually like when something's not going his way and he gets in trouble, then he like goes off the rail and there's no calming him down. Like he doesn't understand what I'm saying to him, no matter how I say it, what I do, what I offer. He's like, you know, broken things. He puts holes in stuff. So I guess there's two questions there. Should I push for the autism stuff? And should I suggest changing his dosage, I guess? Our older son doesn't have any of these tendencies. He's totally mellow and cool, I guess. They're just totally opposite. I don't know if that makes sense.
Dr. Miele, do you want to?
Yeah, I'll definitely address, I don't know if you want to talk about this. I mean, so this sounds pretty serious to me, what you're describing, his behavior at home. So I definitely think trusting that your mom instinct there about pursuing an evaluation is a great idea. I don't know if starting with an autism evaluation, I don't know if you were in the talk earlier with Dr. Truba, who was talking about, you know, the right way to kind of select the evaluation that's best for your kid.
I have a bunch of notes from her.
Because my question is this autism? Is this ADHD? I don't know if, you know, so, and to me, that's almost like two different evaluations to answer that question. At our hospital, the wait for an autism evaluation is longer than a wait for a neuropsych evaluation that can answer an ADHD question.
Okay.
So that could be one order of events. A neuropsychologist might also be able to weigh in on what they're seeing in terms of behavior, and then talk to you a little bit more about if we have red flags for autism, if we have kind of concerns or we're not sure or something like that. But especially since it's getting worse, I really think we probably need to better understand what's going on here. Has your kiddo already had a neuropsych eval?
No, they've never even suggested that. And our neurologist suggested I go to the school. And so I did go to the school and I brought my concerns, but they're like, oh, we can't, unless we have a valid reason to do something like, and she's like, he's great here.
Yeah,
So-
sure. Okay, well, and so it's true, the school is going to be very focused on what is getting in the way of school. So if they're not really seeing anything, then I can understand, unfortunately, your kiddo kind of falling to the bottom of the list. But regardless, I mean, every kiddo with a dystrophinopathy should definitely have a neuropsych evaluation. Because I'm also feeling like where is his overall intellectual ability? You know, do we need to better understand that? Do we have some learning issues? Doesn't maybe sound like that's top priority, but how are we understanding these behaviors? Are they in, like, what are they in the context of, you know? So that would, so I would start there. Outside of the school.
Okay. And then should I bring up the high dose weekends, or should I get the first thing done and then consider the next thing, I guess, would be my, because the weekends when he takes his steroids are definitely worse. And I've said that to our neurologist also, and he just kind of like, it doesn't seem concerning. So then I'm just like, okay, well, you're the doctor, so I just trust him. But then we'll get to the Saturday, and he's like, you know, crazy again.
That's right.
Can I ask you a question? Does he sleep on the weekends with the higher dose steroids? Because I know they certainly can impair quality of sleep.
Yeah, so when we first started, we gave it to him in the morning, and then it was even worse. And so then we moved it to the afternoons, and it seems to help, but he does take longer to go to sleep. And like even his older brother can fall asleep in a second, so he's not really affected the same. But Jax does seem to have a little bit of a harder time going to sleep. But if we give it to him any earlier, the whole day is ruined usually. So I don't really know.
It seems like, you know, trusting your instincts are probably the most important, and you've noticed a correlation there. I think it's worth a conversation.
Yeah, like pushing a little bit harder. Yeah. Okay, thank you guys.
Thank you. I think we have a question over here.
Okay, so my son takes a low dose. We actually started...
Can you come a little closer to the mic where we can't hear you very well?
Okay. Can you hear me better?
A little bit.
So my son takes a lower dose of his Inflazicor. We actually had him, this kind of may go to what the other gal was talking about, because our son was on 24 milligrams of a daily dose, and it was impacting his behavior so greatly that we decided to drop it. We dropped it, and we dropped it to 18 milligrams. So he's not on a full dose. However, the behavior has improved, and he feels better just in general. My question is, what is your opinion on this, a lower dose, and will we have to move forward eventually with a higher dose, even though the whole reason we decreased it was because of the behavior?
I mean,
If that makes sense.
I think that that is a frequently done action with regards to steroid management. I mean, there's lots of reasons to lower the dose, and I think that's something to work hand in hand with your neuromuscular specialist to make sure that you're getting the benefit from the steroid and you're minimizing the side effects. And so, you know, the dose is there because that's where it was set. But everybody metabolizes drugs differently, and drugs are different for different people. So the lower dose may be just as effective with minimizing the side effects. So you may be in the sweet spot and not need to escalate that in the future. But that is just an ongoing decision that you guys should have together. And I do think that it really speaks to the theme here, in that there's a million ways that you can skin that cat, so to speak. And working as a team and a partner with your team to get to the optimal dose is the right choice. Whether it's, you know, high dose weekend, I mean, a lot of, you know, I think the questions that we raised with the high dose weekend about sleeping and about behavior become an issue, and some kids can't tolerate a high dose weekend.
Thank you. We have one over here.
Hi, my question is about mental health, and I'm just, you know, these tween years, there's so much change and transition for these kids, and they're becoming more dependent, their peers are becoming more independent, and so I just want to make sure that I've got the best ways to help my son cope with this. And so, one, looking for just recommendations on coping strategies, but then two, as Dr. Truba said earlier today, like, anxiety, depression, ADHD, all these things are different and present differently in Duchenne. And I want to make sure we're not missing anything, there's no red flags. But what can I look for in a counselor or a therapist who's going to understand or want to understand Duchenne and the brain and help my son cope, and just to stay in front of it, you know, before we get into any bigger issues or concerns down the road? Make sense?
Yeah, absolutely. And it's really great to hear you wanting to kind of get ahead of anything that could be coming, kind of your child could be encountering. And to be completely honest, your question is my question as well. I struggle with this to match therapists to children with dystrophinopathies in our area. And you know, I'm not sure if this is just hopefully kind of an issue just at the moment, but I don't know if I don't know if, like, we need, you know, I would love like a registry of psychologists who have experience or who want to work with kids with Duchenne. So because I feel like finding this match is also in the context of our challenging healthcare system, where is insurance going to pay for it, and, you know, things like that. So the three things that I tell families are, you could look for so, you know, to call your insurance company and figure out, like, get the list of the psychologists who are on the panel. Are any of them, do they at least see children with chronic illness? And then we could try to move to, like, muscular illness, like, maybe, and then maybe dystrophinopathies. You can actually Google Psychology Today, and all the psychologists who are kind of registered will come up with their specialties. I have had some families find success with that. And then it's really just about staying plugged into organizations like PPMD and others who might kind of have some resources and providers who are local. So I wish that I could say, oh, I have got the resource for you, but I just don't think that we are there yet. I hope I mean, I know there's enough interest in this community that we could build something like that, but it takes a lot of work to find a good match for a therapist. But it's a great question too, because I can't tell you how many times families wait and they finally, start, and then it's a bad match and they just stop. So that to me is particularly heartbreaking because we've lost all this time, and then there's a bad association formed, and kids or families kind of don't want to try again. And so I'm hoping that people have a community of a couple of providers at least who you're working with who might have ideas about either people affiliated with their hospital, or we do have a little bit more flexibility now with telehealth, at least like within a state. So a provider who could still be 8 hours away, if you're still in the same state, you can talk to them. So in some ways I feel like the net is growing, but I don't think we're quite organized enough yet.
So the other thing is I would ask providers if there's multiple clinics you go to. So we have somebody who's really on a grant for cystic fibrosis, but she will, if we ask, she will see patients who have chronic illnesses or other things. It's a little bit more on a pro bono type basis for her, but she's open to it, so we don't kind of flood her inbox, but that is just something to consider.
Ask every appointment.
Yeah.
Is there someone else? Oh, is there a trainee? Is every appointment.
Thank you. We have a question back on this side.
Good afternoon. My son is not a tween. He actually, in the state of Minnesota, he goes to the University of Minnesota. So all of his physicians are with the DMD clinic, which is great. It'll continue to be that way even though he's 18. So he's always seeing the same doctors. When it comes to his condition, because he's 18 now, it's difficult to get as much information as I need besides the resources that I have on his portal, even though I've signed all the documents. But I tried to get some questions answered before I came here. It was so important because especially in cardiology and his heart, he also has a condition that has nothing to do with Duchenne. He's got dilatation of his ascending aorta, dilatation of the ascending aortic root.
Yeah, I mean, I think that on echocardiography, you can see some dilation of the ascending aorta that can be trivial or it can be slight, and it has no specific meaning whatsoever. Actually, I just read an echo this morning that had that on it. So it depends, but that said, you can have significant dilation of your ascending aorta that would be associated maybe with other types of genetic problems.
It is. His father also has this condition, and it is larger. He will eventually have to have open heart surgery to fix it. It continues to grow. It's growing slowly, but they're maintaining it with medication. But is it common to see that type of condition in a heart with somebody that has Duchenne? I mean, it's a muscle, obviously. So I'm concerned that, one, if it continues to grow or if it continues to stretch, they're going to have to go and they're going to have to open up and do open heart surgery. They'll have to do it on my husband as well, eventually. And right now he's at a point where I think they go by the number, and numbers, it's confusing when you're reading the reports, but if it hits so many millimeters, that's when they decide to go in and fix it. So I'm assuming the way that they're saying, the stretching, if it stretches to a point where it breaks or it doesn't have enough tissue behind it, then it could be catastrophic. So I'm just curious to know if you've seen those things in a patient with Duchenne, and if there's anything that we can do above and beyond the medications, of course, that they're giving them to prevent it or to prolong it from, getting worse. if there's anything that, in your professional opinion, that we could do, medication-wise.
Yeah. So it is not common because that implies that you have two rare diseases and just sort of misfortune in that regard, that you have two separate problems. So I have not seen anybody with, I've seen a lot of mild aortic root dilation and mild dilation of the ascending aorta, like I mentioned, but I haven't seen anybody who has sort of connective tissue abnormality dilation. And my only recommendation would be, I think if he's starting to approach the point where he would need to have it surgically addressed, I think I would move on the side of getting it done sooner than later, because sometimes they tend to want to delay that and kind of push it out a little bit. But in this instance, I think then what happens is that you lose an opportunity from a pulmonary standpoint to have optimal post-operative care. So, I think the decision making is to get it repaired if you anticipate it to go into that realm. Now, from a medication standpoint, it's unfortunately like Duchenne in that we don't really have anything to arrest that disease at the point of the genetic problem. But people have used beta blockers to try to attenuate the progression of that disease, which is actually something that we use in Duchenne as well. So I don't think that they would go hand in hand in that regard.
Okay, and then do you know if there's any studies going on with, or anything with two rare conditions like this or information that I'd be able to look into as far as specialists goes? His cardiac doctor's been amazing, but we also have to rely on the imaging department. Unfortunately, we just don't have the greatest imaging department, so they're constantly having to redo them or saying because of the images, we're not able to see this portion of the heart. And the U of M is not it's not affiliated with Mayo, but we're also close to Rochester. Do you recommend moving? That's the thing, everything is all in one place, so having cardiology and, the doctor that he's seen forever, and take that portion out and move it to Rochester. Rochester's, one of the greatest hospitals in the world.
Yeah, I'm not sure I understand. I heard all the question.
So I think that the question is, right now his care is all in one place with the Duchenne care and the heart. Should the heart care get moved to Rochester, to Mayo, would that be better care?
Yeah, I think that the problem that's going to be most pressing to you is that dilation of the ascending aorta. And there is no question that Rochester has the capability of dealing with that in a very sophisticated, state-of-the-art way. So I do think, yes, I would probably move I don't even know where you're at for the Duchenne.
Minnesota, it's up in, I'm actually in southern Minnesota, and the U of M is in the cities, and so Rochester is more south, so it's even actually closer to us. So,
yeah, there's no question that Rochester would do an outstanding job with repairing the aortic root.
Okay, thank you.
Thank you. So I have a question for Dr. Benjamin. What about testosterone? How do you evaluate it, and when do you talk about starting treatment?
Great question. I'll meet with families, in the 8-9 year range of age, and we'll start talking about puberty, and because it's a ways off. And our previous discussion group talked about the importance of having a lot of these conversations early, just so nobody is surprised when signs to look for. But what a lot of people don't understand is that puberty is not body odor, acne, hair. Puberty is testicular enlargement in boys, and most boys are not going to share that with their parents, or may not even be sure it's happening. So having a yearly exam after age 10 is super important. Normally, boys go into puberty starting around age 11, and puberty goes from 11 till 15. When you're on high-dose steroids, and no difference with Emflaza versus prednisone in my experience, this blocks the brain message from triggering effectively to stimulate puberty and stimulate the testicular growth and testosterone production. So in classic endocrine circles, we say puberty is delayed if it hasn't happened by 14. And so, I mean, that's usually when we've started testosterone therapy. But I've wondered if that's the best care, honestly, that we may be able to do this earlier. The problem is we never know who's going to go into puberty on their own and who's not, so we want to give young men time to show that they can do it. It's always preferable to do it yourself versus take an external medication. So oftentimes the short answer would be 14 is when we would start the testing. Well, we might test even before then, but a thorough exam after age 10 or 11, get laboratory work that might show us whether puberty has begun. And then before committing to a full-time testosterone replacement, we'll often try to jumpstart puberty by giving a couple months of a testosterone injection and a low-dose testosterone injection. And the whole idea there is you're trying to wake the brain up to then start doing it himself. And I will say that we've had very mixed results with that. Most of the time it hasn't been effective and we've had to start replacement therapy. There are a lot of different forms for testosterone replacement. It doesn't commit your son to a shot necessarily. There are topical gels that can be applied. And in some ways that can be preferable because it's a daily gel that gives a more even distribution of the medicine, so you don't get massive mood swings that sometimes injections can do. Injections are anywhere from 4 times a month, once weekly, to every other month, and we do see some peaks with that, when the testosterone's first given, and then troughs as the testosterone wears off, and you can understand that that might make your son tired or cranky or both.
That's just what we need with steroids already on board, right?
That's right, I know.
Do you see any difference between weekend dose steroids and daily steroids with the start of puberty?
Yeah, sort of in keeping with the earlier question, I haven't yet, but I haven't had that many patients yet on weekend dosing. So, yeah, I can't really comment that there's been a difference so far. But I would say, I don't like the term, I said this before, I don't like the term delayed puberty, because if puberty doesn't happen at 14, we call it delayed. And certainly it is important what family history, how that plays in. If you have one or both parents who've had later puberty, that can also mean your child may be later. So we try to take a careful history there. But oftentimes I'm seeing 18, 19-year-old young men who haven't really started fully into puberty, and that's just because of the steroid, really.
Thank you. I think we have a question over there.
Yeah, another one, sorry. I did come up with one question, but now I have another one for you also, because our neurologist also, again, our son is going to be 12, and his only puberty questions ever are, does he have hair or body odor? Should he be asking us different questions, or should we be asking different questions?
Well, it's not wrong to ask those questions, okay, because they often accompany. If puberty begins, they often do cause body odor and acne, but it's not specific for true puberty. So
okay,
most parents don't know if the testicles have grown, so sometimes we'll ask that question and then do a more, a thorough exam to see whether we think it started. So it's not wrong to ask those questions. It's just not, if they're there, it doesn't necessarily mean puberty has begun.
Okay, good to know. Thank you. Okay, and then my question I came up here for is a behavioral one again, because that's going on in our house. I was just wondering, I know that we've started this whole sibling thing for siblings of Duchenne. I was just curious, have you seen any heightened mental health with siblings of Duchenne with Duchenne? Because I am wondering if that would play a part in my younger son's mental health, watching his older brother go through everything, knowing that he is going to go through the same. Could this really be something that is concerning, I guess?
I think that as we've heard in a few talks, or at least that I've heard in a few talks, kids know more than they say, or they know more than we think they know, and they see more than we think they see, and they hear more than we think they hear. So I think you mentioned your youngest is 5.
He's 9.
I'm sorry, 9.
Yeah, he's
and
9.
he's watching an older sibling with Duchenne.
Yeah, who's much further along.
And so he is watching that. And has he actually asked questions, or do you just think the wheels are turning?
No, I've just noticed, like, we're very open and we're very honest, but I've just noticed sometimes when I'm helping my older son doing some of those uncomfortable, really hard things, sometimes I'll see Jax kind of watching, and you could tell he's just, like, having a really hard time with it, but then we'll try to talk about it, and he doesn't want to, or he'll be like, no, I'm fine, whatever, I don't care, you know? But I know that it's bugging him, but I don't really know where to go with it. And we've tried some counseling stuff, but again, he puts on this front just like at school. He's like, oh yeah, cool, whatever. Like.
Oh, I see. So you have already tried counseling outside of school?
Yeah, we have.
Okay. I mean, I think again, you've probably identified something that is worth further pursuing.
Okay.
I don't know if that relationship with the outside counselor is like completely destroyed, or if it could be kind of resurrected.
No, he was really, really nice. But then COVID happened, and I think this is what happened. They all went virtual.
Yes.
And then Jax was like, I am so over, you know, like he could care less what they were talking about. He'd be like, you know, building Legos, drawing on the wall, like, you know, totally not listening. And I'm like, Jax, do you even want to do it anymore? You know, it's becoming more work for me, and I'm sitting here talking to the counselor, and I don't want to do that.
Right, it's really important for you, and how come?
Yeah, and he's like, no, I don't even care. I don't need to do it. So
I think, so to be completely honest, that's what I hear a lot from families is initially there's just kind of like, they want to just push that away. They really don't want to. They just sort of wish it wasn't something that they had to like talk about, I kind of think, initially. But I do find that if that isn't addressed, we just have a constellation of other difficulties that begin to emerge. And we still have that at the core, which has kind of been at the core all along. Okay. So my recommendation would be to try to
like really push that.
To try to, or at least maybe speak with the counselor again before the start of the session, so that the counselor knows, not to kind of tell the counselor what to do, but to say, you know, what you're looking to get at is this, and so that you can maybe brainstorm with the counselor some ways to kind of engender those questions in your kiddo. Okay. It sounds like there's a technique in psychology called motivational interviewing, where it's you are not attacking the problem yet, but you're kind of building up the ideas to get there. Okay. And it's, I'm not sure about how easy it is to do in children, but that's kind of where we want him to know that it's not, you know, a bad thing to be, you know, maybe feeling scared or feeling mad, or, you know, that's okay. But but starting to work through that is going to be really important for overall kind of coping skills later.
Okay. All right. Thank you, guys.
Thank you. Do we have a question over here?
Hi, I have a question for cardiology. We all know that moms need to get evaluated for cardiology care, and sometimes we may see siblings who are young girls who are also carriers. My question is, do you see those girls in your clinic, and what kind of follow-up and orders do you implement for those female carriers who are siblings?
Yeah, no, I think that's an outstanding question. I think that is a black box. For several reasons. One is that a lot of the young women aren't carrier tested at an early age. They need to wait till they're 18 so that they can give informed consent. So we don't know if they're carriers. Now, there have been families that have circumvented that by saying, you know, my daughter has skeletal muscle manifestations and I would like her genetically tested, and they're able to sort of push that margin and get them tested earlier. So there aren't a lot of younger female carriers that we even know if they're carriers less than the age of 18. And the answer to that is yes. We have seen female carriers who didn't have any skeletal muscle disease have some cardiovascular manifestations. So not a lot, because we're not looking, but I have seen some have fibrosis on cardiac MRI. So in the same way that a mom would need to have cardiovascular care, and what does that mean to that mom? So yeah, I'm kind of choking on this answer in the sense that because we don't know a lot, but I think that if I were a mom of a female carrier, I would be attentive to her cardiovascular health for several reasons. One, it's going to be a lifelong issue for her, and I would engage in connecting her up and educating her about that she will need to take care of her heart, good heart health habits, and and sort of pushing the field to say we need to be addressing that. Not only that, but there's the female manifesting carrier, the girl who really has more of a Duchenne phenotype that I think that we is rarer, but some of you may be in the room, who we really have, I don't think, done due diligence for. So I think we really need to consider the young women with Duchenne as well as the men with Duchenne.
And if I could just add to that, just briefly, I'll just also comment that just as children might not have skeletal or kind of cardiac abnormalities yet who are carriers of Duchenne, I have seen several kiddos, girls who are carriers who have cognitive difficulties. So I would also weave in the, how is learning, how is behavior regulation, do you have any concerns about cognitive development? Are interests equivalent to same age peers? Just because that's another area that's really understudied.
I think that's really important, right? And I think it's important not only for Duchenne, but it's important for all genetic diseases, right? That, these are at-risk individuals, and many of us in the room may be at-risk individuals for a gene mutation, right? And we have not done a great job of understanding Duchenne in general, but we've really not done a good job of understanding Duchenne as in the female carrier. And I think that in the next 5 to 10 years, we really need to change that.
In that direction.
A lot. Because the cognitive issues, the behavioral issues, the neuropsychological fingerprint of the Duchenne mutation, I think is there just in the same way that cardiac.
Probably, yeah, I would agree. So don't forget about that either.
And you're not even touching on the whole idea of what does their reproductive future look like? How do they talk to a boyfriend? What do they tell their husband? How stressed are they? That's a whole nother area.
Well, and we don't even do a good job of asking the questions, right? I'll see a mom and I'll say, well, how's your daughter? Is she affected? And say, no, she's fine. And I'll go, well, when she runs a race at school, is she first, middle, or at the end? Oh, she's always last, but she's lazy, right?
All right.
That could not, that could be from the skeletal muscle phenotype, right?
And similarly for cognitive, right? Because we get that comment too, like they're just lazy. And it's usually, that's like 2% of the explanation, usually, the laziness. It's usually something else going on, so.
Another question?
Yes. My name is Ruth, and I'm not a mother, I'm a grandmother.
Oh, can you talk a little louder?
Yeah, you're a little hard to hear.
My name's Ruth, and I am a grandmother. About 3 years ago, I was just laying in bed after a long shift, and I could hear my heartbeat in my ears, and it felt like it was in my throat. And that was about the time that my grandson was diagnosed. I have a little recorder in me, and I'm getting ready to take that out. And I talked to the lady today about having some testing done. My daughter's a carrier. And I was wondering, when the testing is done, would you recommend me going to someone that actually knows about Duchenne? Because when my cardiologist did all of these tests on me when I was in AFib and bigeminy and trigeminy. I mean, I was all over the charts. And my cardiologist, when I asked him about Duchenne, he really had no idea about it, and he was not even concerned. And because I felt bad, because I felt like I was the one that initially, that's why my daughter became a carrier. So that's my first question.
Yeah, well, why don't we answer that, and then we'll let you do the second one, just so we don't. Yeah, you know, your story is so commonplace. There are a lot of women walking around whose physician never connected the dot between their cardiovascular problems and their son's or their grandson's diagnosis of Duchenne. And, you know, because this is sort of my personality, I kind of want to go, shame on them. But the reality of it is we can't know everything about everything. And you may have an outstanding cardiologist who just didn't Google Duchenne because he or she was too busy moving through their day, right? And so sometimes you have to push them on that a little bit. You have to say, no, my grandson has Duchenne muscular dystrophy, which is a neuromuscular disorder that can be associated with cardiovascular problems. You know, there is a high likelihood that my cardiovascular problems are related to this. And at that point, they should engage, right? They should change their dialogue on you. And if they're not changing their dialogue on you, then you might need to change your cardiologist. Because I think a good, or good is the wrong word, but a person would say, oh, you know something? I'm going to look into this, and oh my gosh, you are right. This could be true. Let me talk to a colleague. Let me get some more information about this. Let's make this work, right? But your story is, I've heard that a million times. And so I think, but that's one of the benefits of coming to conferences like this, because I think that information can be shared. I think that information can be disseminated within the community, and I think it's organizations like PPMD that need to disseminate that information. I don't know if you're going to be able to touch the providers, but you're going to need to educate the individuals to advocate for themselves when they go into those clinics, because it's tough. There are definitely cardiologists in this country who are very Duchenne savvy and who focus on Duchenne primarily. But I would say there's a million cardiologists who don't, and a million great cardiologists who don't. And but your story, you're not alone in your story.
Thank you. My other question is about the GI tract. I know that steroids can cause, you know, acid reflux, but do you see a correlation with the severe constipation? I know it's not something that people talk. I don't feel that we talk about it enough, because I know when everything's moving through me, I feel like a better person. I feel like a nicer person. And I wonder if that is some of the mood disorder sometimes, is when we don't have everything moving through. Do we talk to parents about that? Last year when I was out and I spent a longer time with my son, my grandson and daughter, he was like, I can't eat. I am not hungry. I feel sick. Well, it was because everything wasn't moving through so well. And yeah, he was a little crabby. But she has talked to the doctors, and they have him on a better regimen. And because my theory was, don't be afraid to give him something to help him out. How do you feel about that? Do you have People ask
I
questions.
was just in the last hour with the GI doctor from Nationwide, and a couple points he made were that, you know, don't be reassured by the presence of bowel movements. You know, don't let that make you think there's not constipation there. So
Right.
making sure, you know, your grandson has an evaluation with a specialist in gastroenterology is important, because sometimes I know I would have made the mistake of asking that question and going on to the next one. It's a very important problem and a very common one, judging from the parent group who we just had an hour-long discussion with.
I'm blown away, actually, by how common it is. Kent Williams is the GI doc who works in our clinic, and he has really engaged with the Duchenne community. And when we added him to our clinic, it blew my mind, because we're not asking the questions that we needed to ask, right? I mean, we're trained to ask questions inside our box, right? And it was you know, the neurologist would come out of the room and say, no, there's no constipation problems. And I'd go, Kent would come out and go, you know, we're going to schedule him for the OR and disimpact him. I mean, you know, 2 minutes later, you know, the bowel is a muscle too. That's all I've got to say. You know, the GI tract is a muscle too. And so, you know, GI problems are common. Swallowing problems can be common. And you are exactly right. Toileting behaviors and are extremely challenging, and getting those I would get connected to a good GI doc.
Well, he's doing much better, and that's what my daughter has done. And I guess I was just wondering if it was something that's talked about in this community, and that whatever specialists they're seeing, that the specialists themselves are referring them to someone else and saying, you know, let's get going with this, because, yeah.
I applaud you for bringing that up, because I think it is talked about in this community. Obviously, there was a noon session on GI problems, but it's not talked about probably enough.
Yeah. Well, thank you guys for being here. I appreciate you, and I've appreciated being here with my family. Thanks.
Thank you very much. I have a question for Dr. Kaslow. So what about BiPAP? What do we do when we can't get our sons to be cooperative wearing their BiPAP? Do you have any tips to do some desensitization?
You glue it on their face. No.
Yeah, this is the number one problem, I think, as a pediatric pulmonologist with guys with Duchenne that we run into, is non-compliance with BiPAP. So I mentioned that we have a psychologist with our CF population who assists, who specifically has been like taking training to help our sleep docs with desensitization. And so she's been very helpful in that regard, because we can have them do sessions to do it. What I like to do for the initial part is just even if it's a couple of hours. I mean, for compliance purposes, to not get the machine taken away, which is in of itself kind of another big issue, is they need a minimum of 4 hours a night for about 70% of the nights. And so what I say is that's what we're shooting for when we start. I mean, we shoot for 100% in all of them, but the ones who families come back at in about a week or so, we usually try to do like a telemedicine visit. That's what we shoot for, is 70%. 4 hours a night, because I think that's the first big hurdle. Because once I think we get that, what I've seen, at least somewhat anecdotally, is it kind of snowballs into, all right, we've been wearing it 4 hours, I can kind of sleep with it now, and then that goes into using it all the time. And the vast majority of our guys say it's beneficial. And they'll wake up and they'll say, the nights that I wear it, or the nights that I don't wear it, I can tell the next day. And then those are the ones we don't worry about compliance anymore, because they're just, a lot of times we'll hear families say, gosh, yeah, he's back. I mean, like because the carbon dioxide levels have been going up and up and up for years. And then finally we get a BiPAP and we're using it consistently. And now we're sleeping well for the first time in who knows how long. We also trying it during the day, so it's not like we're trying to put it on. We have air blowing in, trying to sync with it while we're going to sleep. So sometimes we say just during the day, we'll try it, and we're just going to try to focus on breathing with it. And so doing it that way, because it's the same, we have the same concerns with other populations that need use of positive pressure ventilation. And so those are the two big ones, is doing it during the day and shooting for, at the minimum, 4 hours a night for 70% of the nights, if not so that insurance doesn't take it, and then we have to redo the entire process over. And then if we really have to, we will get some of our sleep medicine docs involved to see, well, desensitization, have these initial therapies or these initial interventions not been useful? Well, we'll then bring in our sleep medicine doctors who potentially can have some other tricks as well.
Thank you, that's great. I think we have a question over here.
I actually have two questions. My first is regarding neuropsychology. I wondered if, because this age group in particular is a definite time of transition, both physically and mentally. I wondered if there were any trends that you're seeing in boys with Duchenne in their mental and behavioral health. My son's autistic as well, so he does get, talk and play therapy. He does have people that he can speak to outside of the home to share some of those big feelings that he has. But I wondered if there were just trends that you see in those boys, and whether or not he has obviously received a neuropsych evaluation, whether that's something that you would just sort of monitor, or if he should receive a full neuropsych evaluation again after a few years, because it's been about 6 years since his first full evaluation.
Okay, sure, great questions. So for your first question, the trends that I see do you mind telling me your kiddo's age?
He's 12. Reed is 12.
I think you said that, I'm so sorry. So what usually happens is that parents come in with increased concerns, more inattention, more difficulty with school, more difficulty with peers. When I do my testing, I see that levels of performance are pretty much in the same area. We haven't lost any skills. We've gained the expected number of skills that I can kind of quantify in my testing. And so what I think is happening is there's more demands on these kiddos in every domain: school, friends, relationships, physical, and the physical changes that you mentioned. So this can look like we're maybe experiencing cognitive problems, but actually we just need to adjust some of our coping and other supports to help that, if that makes sense.
Definitely.
And then to your other question, so yes, definitely. So neuropsychology is a consult-based service, but I like to have my kiddos on, if I can get them on the trajectory of every transition period with school, that's my favorite. So kindergarten, 2nd grade, 4th grade, 6th grade, 9th grade, 11th grade, all evals. That would be kind of my ideal, because I like to see kiddos after they have started that transition. So once we're a few months into 6th grade, once we're a few months into 9th grade, because this gives the school, frankly, this gives the school the opportunity to do it the way they want to do it, which is fine. They'll likely have a previous IEP that they can work off of, and so they kind of start there, and then we see how it goes. And so then the parent is able to say, well, this is fine, but this, and this are bad. And so then I can use my eval and kind of go at it like right away. And I feel like we both get kind of the most bang for our time together.
Thank you very much.
That makes sense.
Definitely, yeah. And then I just had a quick question for endocrinology. Could you speak to, could you help me understand a little bit more why the concern about the delay for puberty? Is it just a matter of like, this is what your body's supposed to do, and if there's a delay, like, then we need to fix that? Or, what are the benefits, of addressing those puberty-specific issues, and when they
Sure.
come up?
Great question. Well, I think oftentimes there's a self-esteem issue too, you know, not going through some of those physical changes you may see your peers experiencing. And certainly we get through the middle school and into the high school years, that becomes more noticed, you know, voice changes or lack thereof, facial hair. So external, the lack of those external findings can be troubling to the young man. I think testosterone also has an important role in bone health, and that's one of the big topics that, you know, I see in any patient on long-term steroids, glucocorticoids. There is, you know, testosterone has some impact on muscle, but I don't know how significant an impact it has in young men with Duchenne. But so it plays an important role, though, in overall health and you know, quality of life too. You're just noticing that you're going through what others are.
Thank you very much.
Anybody else? Oh, here we go. Got somebody here.
Yeah, it's just a quick follow-up to her question. Is there anything that we can do as parents heading into puberty that will help bring it on naturally? Or is it just truly like we're up against the steroids that are suppressing it? Is there just anything, any tips or tricks, or is it, can we do a better diet? I don't know, you know, anything like that?
So your question is there anything you can do to
help?
Oh,
As the parents to help, you know, move this along naturally.
Not really.
Okay.
You know, just careful look at the steroid dosing and make sure you're challenging that or talking about that regularly, because it does seem to be directly related to the dosing. I mean, but whether it was someone else brought up going from 24 to 18, I don't think little subtle changes like that will make much of a difference. Okay. No, it's usually something that happens when it happens, but no question the steroids are the culprit.
Right. Okay. So we assume, but we just always want to make sure we leave no stone unturned as parents.
No, that's a good question.
I was wondering, Dr. Benjamin, if you could expand on bone health. What are in this population, we hear a lot about fractures, and it's so scary when somebody breaks their femur, and then FES comes into play in the emergency room, fatty embolism syndrome. So could you talk a little bit about bone health?
Sure. Absolutely. It's an hour-long talk in and of itself, but I'm happy to touch on it. I think when you have a problem with muscle, you're going to have a problem with bone. I think people don't always appreciate how important muscle is for pulling on bone and strengthening it. So at the outset, there can be an issue with bone health, but probably not one that comes to attention until steroids are started. We know that steroids thin the bones. They tend to slow how well your building cells, your cells that build bone work, and they increase how well your cells that break down bone work. So we get a gap or a difference between how well you're breaking it down versus how well you're building it, and that's a setup for fracture. I think it's easy to see fracture if you're performing cares or your child reaches over to pick up a newspaper and breaks their leg. That's you know, unfortunately very easy to see, and the pain that comes with it. One of the less appreciated fractures is the spinal cord, the vertebral fractures, and this is something you may not pick up on, or may be subtle. Maybe that your son is complaining of subtle pain that you think might just be how they're sitting, or that's harder to diagnose and to pick up. But I think fatty embolism syndrome can happen with any major break, long bone break, and can be quite dangerous. But fortunately, I have not seen that in my patients, but we have seen a lot of fracturing once glucocorticoids are started, and especially higher dose. We can give medicine that help the bones thicken. Usually that's most effective through IV and not the oral forms. And particularly if you've had back problems, the IV forms are the more effective. But it should be noted, they don't reverse the effects of steroid. They just try to help strengthen your bones through a different mechanism.
And do you typically start them at a particular age? Do you wait until there's symptoms? Do you wait until the DEXA scan indicates a problem? What is the process for that?
Yeah, what you're getting at is the bone density scan. We found those are difficult to read for when to start, because almost every young man on with Duchenne on high-dose steroid has a low bone density. Usually we've done it with when there is a risk, and we know high-dose glucocorticoids for even a couple years is a risk. If you've had a fracture or you have back pain and the vertebral fracture, that's usually been when we started the therapy, because it's not a reverse of what the glucocorticoids are doing, and because that medicine itself can have some side effects that aren't, are not pleasant.
Thank you. Do we have any more questions? We're getting close to our time here. One more over here.
Just to follow up on your oral versus IV bisphosphonates. So do you have a protocol in place for when you do give one or the other, or are you just giving IV bisphosphonates at this time?
Usually it's been IV just because we haven't had as much luck with the oral, particularly if you also have other GI side effects, reflux and other pieces. That the oral forms have been known to cause some gastritis, but they just aren't as effective as getting deep into the bone. Fortunately, there are some longer duration lasting IV forms, so patients can get it every 6 months as opposed to every 2 or 3 months, which is how we started. The infusion only takes about an hour, and I've been able to try to work with home health to get more of this done at home to keep from disrupting lives, as little as possible.
Thank you. Anybody else? Well, I want to thank our panel today. Thanks you for your time and your wonderful information, and I know the community finds it so helpful when they have the opportunity to speak with experts like yourselves. So thanks very much.